Yes, we can see them.
Yeah, great. Well, okay, I'll start then. Welcome, everybody. Sorry about the technical issues. It said there was more than 100 of you online and it wouldn't let me in as a 101st participant. So it's nice to have you all here. I'm going to talk to you about an intro to evidence-based medicine and then start thinking about formulating questions and thinking about systematic reviews and how you might go around developing questions. In the next lecture, in about a week's time, we're going to then think about, there's going to be a bit of work, hopefully, for you in between. Then we'll think about a protocol for a systematic review. So one of the key things about evidence-based medicine is it isn't a passive learning experience. It's about being active. And one thing you can do is if you go to... Sorry about this.
Could everyone please mute the mic?
Can everybody?
Yeah.
Okay, sorry. Okay, you can go to cebm.oxford.ac.uk and we've got lots of resources there. Just to let you know about myself, I'm not only Professor of Evidence-Based Medicine, I work as an urgent care general practitioner, going around doing visits, interacting with people in their homes, so I work regularly as a clinician. So, this is a slide of a condition called phocomelia. And as you can see, these are children who have suffered from a congenital malformation. And this was in 1958 when the drug thalidomide was released around Europe and the United States of America. But importantly about this drug thalidomide is most people won't know who this lady is. And this is Frances Kelsey, who's receiving a Distinguished Service Medal from John F. Kennedy in 1962. Now, she got the medal because basically most people wouldn't know what she did about 50 years ago. She transformed the way prescription drugs are regulated. She was a new employee who basically asked for more data on the drug thalidomide. In America, it was called Kevadon, realizing that there were issues with neurological complications, but also birth defects, and required that the drug was only delivered in the US based on the need to be in a clinical trial. That meant in the US there was only about 17 babies born with thalidomide, as opposed to over 10,000 in Europe. In the UK alone, we had over 2,000. So a massive discrepancy. So this was the start of the requirement for drug regulation. So if you think about pathophysiology or your anatomy, all of that learning, that's been around for hundreds of years. But our approach to regulations of drugs is only about 60 years old. So actually it's relatively new in terms of our understanding of the whole of medicine. Now, in the 90s, there was a growing realization that much of medicine was not based on evidence, that it was based on people's opinions, what they thought was the right thing to do. And this is an important editorial that sets out what evidence-based medicine is and what it isn't. And EBM is the integration of three issues: the best available research evidence with clinical expertise and patient values. Now, the best EBM occurs when we get right at the intersection of all of these three issues. Just evidence alone is not sufficient to make decisions. In your training journey, you are learning the skills of clinical expertise, how to make diagnosis, how to communicate with patients, how to elicit their preferences and values. In doing so, all of those three issues go into making an approach which is evidence-based. And I think if you are evidence-based, it can have a number of benefits. It can underpin your clinical decision-making. It can quantify the benefits to patients. It's not about just saying a treatment works or it's beneficial. Importantly, by how much? How do you describe that effect to patients so that that can underpin and inform their decision? And that is what we call shared decision-making with patients. In the 80s and 90s, there was an approach that was very doctor-centric, whereas now we've moved to what we call shared decision-making, which is a patient-centered approach where the decisions we make are informed by the best available evidence. Can also improve your diagnostic reasoning, understanding issues like sensitivity and specificity, but also likelihood ratios can really make you a much more skilled clinician when it comes to diagnosis. It also is this issue of understanding the benefits versus harms. All treatments come with harms. Therefore, our approach to medicine has to be about an ability to determine the net benefit versus the harms. And that ratio is important in terms of the decision. I also believe, and that's why I got involved in evidence-based medicine, when I was a medical student, it allowed me to learn medicine more efficiently, to be able to understand where there's high-quality evidence to help underpin my decision-making versus the sort of variation that you see in clinical practice that is hard to understand and apply. And I think it also allows you to be more safe in your practice. So what we talk about, and I talk about, is the 4 A's. Asking clinical questions, acquiring the best evidence, appraising the quality of the evidence, and applying in practice. Now, if you notice, this ask the clinical questions arms is much, much bigger than any of the other steps. That's because you should be asking many more clinical questions about the patients you see than actually you can't look up all of them. You can't appraise the quality. And actually, many times we don't apply in practice. For instance, if we find no benefit of the treatment, we won't be applying it in practice. So it's a sort of, this is the number one skill to develop these 2 important steps, which then allow you to then appraise and apply in practice. So I'm going to talk to you about asking questions. I'm going to talk to you about 2 different approaches. The first is your general questions versus what comes next is the specific questions. Now, general questions are all about a condition. What are the risk factors for COVID? What are the symptoms and signs? What are the tests? What are the thresholds for treatment, for diagnosis? What are the complications? What is the prognosis of my patient? All of them are important questions to ask, but they are where you start your medical journey, filling in that general knowledge about a condition. Once you have that general knowledge, then you move on to what we call specific questions. And these specific questions are about actual patient care decisions and actions. You understand what COVID is, you understand what tests, what treatments to use, but you now have a patient in front of you and you have a specific question to ask. In doing so, we have a very clear acronym. It's called the PICO. In patients with COVID, does the giving dexamethasone compared to placebo reduce mortality at 28 days? So if you take one thing away today, it's this: P is for patients or population, I is for intervention, C is for the comparator, and O is for the outcome, which you may also have a time point to. So that PICO allows you to formulate an answerable clinical question. And if you do that and use that strategy, what you do then is you're able to start to plug some of the terms into PubMed, which is the most efficient database to be able to go searching because it's free, it has no logins, and allows you to acquire the best evidence efficiently. In doing so, here's an example. You come across the randomized controlled trial, dexamethasone in hospitalized patients with COVID-19, and this is an open label randomized controlled trial of 2,100 patients. You can also interpret the outcomes. Now, this is important to think about why evidence-based medicine is important, to focus particularly on the patient population. So if you look here, this patient population on the top left is all participants. And what you can see here is that this is the mortality. So up here is increasing mortality. And here's the day since randomization up to day 28. The black line is the usual care. And you can see there's a separation from red line of dexamethasone. And what you can see is there's a reduction, a rate ratio reduction of about 17% in the risk of mortality. But importantly, here you can see that if you look at those with invasive mechanical ventilation, actually the separation is much greater. And actually, the rate ratio here is a 36% reduction in mortality in those in mechanical ventilation. You can also see it in the bottom left here in the usual care arm, that you can see that actually there's a difference, but it's not quite as great as that you saw with the mechanical ventilation, but that's in the oxygen only group. But look what happens here. In the no oxygen received, the red line is above the black line. Actually, dexamethasone is potentially more harmful than beneficial. So what that does allow you to do is to think, not only is it about the patient group, the specific patient groups that would benefit from the intervention. So here you can see it's in patients with COVID on invasive mechanical ventilation or oxygen compared to placebo will improve outcome. But those without oxygen or mechanical ventilation, you may harm. It's a good example of using a clear clinical question to find evidence to then specifically answer it. Now, when you do this approach, what you'll find is when you start out in the experience with the condition, so when you start medical school and you start your training, you have many more general questions than specific questions. But actually, as you go on in your training and as you start to get now and as you become a qualified doctor or a registrar and ultimately a consultant, you have lots of specific questions about actual patient care decisions and actions. And that's where your evidence-based approach starts to kick in. Now, once we've learned how to ask questions, the second aspect is acquiring the best evidence. Now, importantly, in terms of acquiring, what do we mean by the best available evidence? Well, this is an important editorial that was wrote 1994 when I was in medical school, 30 years ago now, by Doug Altman in the BMJ, The Scandal of Poor Medical Research. He basically said the problem here is there's lots of research that actually is poor quality. It's actually fails in lots of ways, and that we need less research, better research, and research done for the right reasons. But here's the problem you face. This is a graph of the number of papers published on indexed on PubMed. So in 1995, it was about 450,000 papers a year. And as you can see, it's gone up and up and up. In 2021, it was 1.786 million. In fact, what happens is these will continue to go up as they get indexed going back. And it's already approaching 1 million papers this year. So you have a huge task if you consider there are nearly approaching 38 million papers on PubMed to be able to keep up to date and find the best available evidence. So you need skills to track down the best available evidence. In doing so, what we talk about is the pyramid of evidence. At the bottom is your editorials and expert opinion, and at the top is higher quality evidence that includes randomized controlled trials and systematic reviews. If you was in my clinic and I gave you my opinion, I would expect you to go and look up the evidence to ensure that I was correct and up to date. And I think that's a fair approach. Now, let me give you an example of thinking about expert opinion. Would you ever have put babies to sleep on their tummies? Now, this is an important question because in the 80s and 90s, this is one of the most sold books in the world, which was recommended for patients ever published. And it was published in 40 different countries. And the advice in those days was actually that to put your sleep baby to sleep on their front. The disadvantage to a baby sleeping on his back, if he vomits, seems more likely to choke on the vomit. Well, that makes sense. That's a mechanism. That is an opinion. It makes sense if you think about it. And therefore, you end up with a statement is, I think it is preferable to accustom a baby to sleep on his stomach from the start. Now, what's the problem with that approach? Well, actually, if you start to look at the systematic review evidence, that actually, before the early 90s, parents were advised to place infants to sleep on their front, contrary to the evidence from clinical research. By 1970, there was a statistically significant increased risk of sudden infant death syndrome for front sleeping compared with back. Pooled odds ratio back, it's about threefold increase. And if you look at the meta-analysis, you actually see over time, this is the cumulative meta-analysis, that the effect gets stronger and stronger. that actually there's a fourfold increased risk of sudden infant death syndrome just from sleeping on your front compared to your back. Now, if you think about it, this is a simple evidence-based approach, and this is data from the United States of America. The green line is the campaigns that increase the proportion of babies sleeping on their back compared to the front. And then this is the decrease in the rates of deaths per 1,000 live births. You're talking over a 15-year period about a difference of about 1 death per 1,000 live births just from sleeping on your back compared to your front. Now, that's an important aspect, and this is where public health comes in, because this is a simple intervention that's evidence-based, based on systematic reviews, but you can see there's always a small proportion of people that the information and evidence doesn't filter through to. So that's an example of systematic reviews. Now, just thinking an up-to-date example of a systematic review, here's a good example. Should I give Tamiflu to children if they have a fever? Now, what you can do, again, you can go into PubMed and thinking very simple, my P is children with influenza, my intervention is Tamiflu. I'm not even going to put them terms through. I'm going to search very quickly. One of the problems here is if you just put them, you get 4,500 results. It's implausible for you to consider that you might go through those 4,500 results. So what we do is built into PubMed is these article type, which allow you to have the filters to get round to the systematic reviews immediately. And when you do that, you go from your 4,500 articles to 84 really quickly. And that's the way then you can filter down. And if you do that, you can come to a systematic review that we did as one of them in there in the Cochrane Library. And I'll come back to this review. But remember, in PubMed, you have filters to be able to get to the high quality evidence. So just a recap, we've talked about general questions about the condition, the what, the why, who gets what are the tests, what are the treatments, what are the complications. Most patients want to know, what's my prognosis, doctor? What's going to happen if you do nothing? Versus the specific questions. Here's another question. In patients with heart attack, does cholesterol-lowering therapy compared to usual care reduce mortality? You could introduce a time component, 28 days, 1 year. But they're the sort of important questions that patients want to ask you. So how do we go about building a clinical question? Here's a good example. This is just a simple one. Mrs. Wish is a 28-year-old solicitor. She comes to see you frustrated by symptoms of irritable bowel syndrome, incredibly common condition. She feels they have got worse, and despite numerous things you've suggested, nothing has helped. But she's read an article in the newspapers that probiotic drinks might help and asks you, what do you think? Now, in constructing the question, we like to think of it first to start with the broad and specific nature of a question. So here you start with broad, adults with IBS. Intervention might be probiotics. Comparator, no probiotics. An outcome, improved symptoms. That's quite a broad question in terms of its structure, but you could be more specific. You could think about gender, age, how long have they had IBS? Are you talking about males or female? Is this chronic IBS or is it an acute presentation? In terms of probiotics, what type is it? Is it a tablet? Is it a drink? In terms of the comparison, are you comparing it to placebo, to standard therapy, or advice? And in terms of outcomes, which ones are you interested in? Are you interested in all of them or some of them? And so you start with a broad thought about your PICO question and then narrow it down. I got asked a question yesterday about children. Well, not all children are the same. You wouldn't compare a 1-year-old to a 14-year-old. So you might be, a PICO might be in infants with a fever. Does Tamiflu compared to placebo improve outcomes? Now, that's a sort of very specific about a PICO. So remember, I'd like you to commit that to memory. Now, where does systematic review fit within the sort of architecture of clinical questions and processes? Well, here's a flow of thinking simply about research and patient presentation. Etiology, what knowledge about causation, what causes this disease. When a patient presents, you need to have information about diagnosis. Now, also, if they're asymptomatic, you might be thinking about screening, early detection worthwhile. As you move down, you might be thinking about using tests, how accurate are the tests? Once you have a diagnosis, there's knowledge about prognosis. What will we happen if we do nothing? And then you've got therapy, which actually is designed to change the prognosis of a patient. Does this intervention help? What are the harms of the intervention? But also importantly, what are the rare harms? And that's the clinical outcome. So we think about systematic reviews generally in 7 different questions. How common is the problem? Well, that's an important issue that is amenable to systematic review data. You can be contextual. You can look at it in specific areas like the UK, Palestine. You can look at it in wider areas in Europe or in the globe. But actually, how common is the problem? And I'll show you examples of all of these. Early detection worthwhile. That's about screening. Once you have a patient with symptoms and signs, are the tests accurate? What will happen if we do nothing? Prognosis. Does this intervention help? What are the common harms? And what are the rare harms? And remember, we formulate our foreground questions into PICO. So here's some examples. These are people who've come and worked with us and done systematic reviews. This is a Tibetan doctor in the relationship between altitude and the prevalence of hypertension in Tibet, a systematic review. We conducted a systematic review. Sorry about this. We conducted a systematic review of this question. Now, next one. Is early detection worthwhile? Here's one: self-screening and non-physician screening for hypertension in communities, a systematic review. This is an important aspect in many countries in the world where there isn't an organized healthcare system, there isn't general practice. What's the best way to pick up blood pressure, if you like, and hypertension and screen for it? Here's a diagnostic one. Viral cultures. Is the diagnostic test accurate? Here we're looking at the relationship of PCR testing and its relationship to viral culture. And we want to know how accurate is the test. What will happen if we do nothing? A very important question. And here's one that was published in the BMJ. The duration of symptoms of respiratory tract infections in children. Just look at the answer, the conclusion. The duration of earache and common colds are considerably longer than current guidance given to parents in the UK and the US. For other symptoms such as sore throat, acute cough, bronchiolitis, and croup, the current guidance is consistent with our findings. Why does this matter? Well, again, it's about informing patients. If you get the duration of the infection wrong and you don't present it as long enough, they're likely to re-present saying, why has it not got better? Why is my child still unwell? In doing so, using an evidence-based approach can inform the decision better. 5, does this intervention help? As I showed you, there was the one about Tamiflu, and you can see there, you end up in, if you get the question right, you end up in the major news story. And what we showed is that the drug is largely ineffective. 6, what are the common harms of an intervention? Here's one about pregabalin, which is used in neuropathic pain. And what we did is address the specific question about harms. And then finally, here's one about rare harms. And what are the rare harms of interventions? And here we're looking at anti-obesity medicine products and the withdrawal from the market. There is actually an 8th question, which I haven't done, which I've put in, is the why. And you can always ask why in systematic review. And here's a question about primary care clinicians' attitudes towards point of care blood testing. Instead of doing a qualitative study, we go off and systematically review what's gone before. And in doing so, we can identify what's already known and not waste time doing a primary study and go and look in all that literature. So just to remind you, here's the 8 questions. I put together the 8 questions, and I think these are all the ones that are amenable to systematic reviews. You can have clinical questions in all of these, but here's what I want you to think about now. I want you to just think about your clinical questions and to think about what was the problem that you considered? What was the issue at hand? Once you've got that, you then construct a PICO of the problem, thinking about all of the issues that come with this problem. What's the most important question? Thinking about the patient values and preferences, what's important to the patient, but designing a question. And here's an example of one. For instance, this is Mr. X is a 58-year-old obese gentleman suffering from non-insulin-dependent diabetes mellitus. The problem is we want to know whether the drug metformin could improve his condition as measured by lowering his glycosylated hemoglobin. So you've got a P, population, obese adults suffering from non-insulin diabetes. Intervention is metformin, comparator placebo, and the outcome change in glycosylated hemoglobin. You could go and look for the evidence, and I've looked at the evidence. I know the evidence. I could look at the guidelines and consider how to put that together. But once you've got your clinical question, you've done your first two steps. Your third step is deciding how to decide on the important outcomes. You've got your population, you've got your intervention, you've got your comparator. There are multiple outcomes you could look at. And therefore, what you want to do is think specifically about the important outcomes. To do that, you've got how to decide on outcomes. You've got these 5 sorts of things to consider. Always think about what's the important issues to the patient. So, for instance, doctors, we may be interested in the physiological measures, the blood pressure, the CRP, the troponin level, all of these features. But the patient might be worried about fatigue. Can they go back to work? What's going to happen to me? There might be the critical outcomes, such as, am I going to die, doctor? So you think patient-centered. Often to decide outcomes, they're not something we do on our own. We think about speaking to clinicians, the patients, and public to get a sense of what are the most important outcomes. They also must consider the harms of intervention. It's not just about the benefits, you must consider the harm. They should be extensive in nature in a systematic review. And sometimes you have to think outside of the box of what your traditional learning is. And that's because one of the most important examples of this was like rheumatoid patients. They formulated their own patient-centered group because nobody understood that one of the biggest issues in rheumatoid disease is the fatigue that comes with the condition, and that most people and patients wanted interventions that would improve their fatigue. So when you think about outcomes, you also want to put them together, and this is in a sort of strategy of prioritizing the outcomes. At the top, you have critical for decision making. Which are the ones that will really influence decision making? Here, for instance, you've got in infection, you've got mortality, hospital admission, pneumonia. They're critical for decision making. But down the list, there may be some that are important, but not so critical. And then at the bottom, you've got a low importance. And this is a strategy the World Health Organization uses. They basically score interventions when you look at the outcomes to try and say which are the ones critical that we want to include in our PICO. So when you do that, you end up with a population intervention comparator and the critical outcomes, which may be your primary outcomes, and your important but not critical for decision making will be your secondary outcomes. Now, just important in your clinical questions, you write down your problem, you PICO, decide the important outcomes, but then you're going to formulate your primary outcomes, that's your 3A, and then your secondary outcomes. And that's important to determine those two. In doing so, here's an example from the systematic review that I showed you we did on Tamiflu. Here's all of the outcomes. This is for 2 different types of studies. There were treatment studies for Tamiflu and prophylaxis studies. Treatment is where you give somebody who has influenza or COVID the actual treatment. Prophylaxis is when you may be giving it your family members to prevent them from getting COVID or influenza. So here's the primary outcome measures. Symptom relief, that was an important issue for patient. Second, hospitalization and complications. And then third, the harms. Now, they're slightly different for inside, but here look at the secondary symptom. Symptom relapse after finishing treatment. Okay, I had 5 days of treatment, but did it come back? Drug resistance, viral excretion, and here mortality was rated lower. But you've got a system for primary and secondary outcomes that you would formulate within your review. So you have a strategy, right? Now, once you've got that, the fourth step is to look for a systematic review to answer your questions. And that's important because you've developed a PICO. You want to know, has somebody already done the systematic review? Is there an answer available? In doing so, one of the features we've devised is this table of levels of evidence, thinking about the study, the best design. And this has been around and is highly cited, and it's available on the website that I showed you. If you go to the CEBM and look up levels of evidence, you can access this. And this is useful because it's got all of the 7 questions that we talked about down the left-hand side. Starting with how common the problem, here early detection worthwhile. One of the key things is as you go across, you go from level 1 to level 5. And here we have what we call mechanism-based reasoning or opinion. And over here we have the highest level of evidence, systematic review evidence. So here, if you're interested in does this intervention help, you're looking for a systematic review of randomized trials or N of 1 trials. As you go across here, you go into lower quality evidence. Now, what it means is, doesn't mean if you have a question and there's only case series controls and that's all you found, what we would ask you to do is look for higher quality evidence. If it doesn't exist, then this is the best available evidence. But if systematic review evidence does exist, and you're talking to me about case series or controls trials or non-randomized trials, I will tell you that's not the best available evidence, and you should go back to the levels and look for the higher quality. Use your filters to direct your search. So this strategy talks to about the types of questions, but also the higher quality level of evidence. Now, so here's your strategy, and I'm going to take questions after this because this is a very clear piece of work which gets you to formulate your questions, your clinical questions. You write down your problem. What's the patient problem you're interested in? Or maybe you're aware of, it may be a family member, the last patient you've seen, something that keeps coming up. What is the PICO of the problem? The population, the intervention, the comparator, and the outcome. Once you've done that, what are the important outcomes? And as we said, step 4 is look for a systematic review to answer your question. Now, if there is a systematic review that's up to date and addresses your question, then you perform appraisal and look for the effects. How much benefit, how much harm does this make a difference to practice? If so, you've got something to apply in practice or may confirm what you're already doing. But step 5B is, if there isn't a systematic review, or it's out of date, or it doesn't address your PICO, for instance, it's a different population. For instance, you may want to narrow down the population to a particular setting. It may be the outcomes of interest, it doesn't address them. Then you have the ability to now understand where systematic reviews come from. And that's how we derive many of our approaches. This is the approach of how we get to doing a systematic review. And I think this structure allows you to have a strategy. Remember, I've showed you about how to use PubMed, to use a filter of systematic review to address 5A. When you get to 5B, you can then think about how do you go about addressing whether a systematic review is worth doing. And in doing so, I want you to focus on performing a systematic review is a team-based exercise. Now, as a team-based, you have to get together. We do this, we get together as a team and we discuss our problems, discuss our questions, discuss what we found, and then consider which one's a high priority for us to consider, should we do a systematic review or not? Which one's a higher priority to influence practice and make a difference to practice and perform an appraisal of? And there you've got a team-based exercise where you're moving forward. So I'm going to stop at that point and just say, I'm going to take questions now about anybody's got particular problems or questions they're thinking about, and strategies for thinking about you developing a question going forward. Okay, over to whoever's convening.
Okay, so I can moderate this since we have
Yeah.
some people who raised their hands.
Yeah.
We can start with Yusuf.
Hey, doctor, thank you for times, but I was asking about just clarifying about performing appraisal if I found a systemic review about my beacon.
About performing an appraisal. Could you just repeat? You found a systematic review. Yeah. Could you repeat the question?
Yeah, but just I want to clarify how can I do or perform my appraisal after I found a systemic review on my beacon.
Yeah. That's another. I guess in the protocol, when we do the next session, we'll think about all the important relevant bits of a systematic review and and what they should look like. And in doing so, once you understand the next session of the protocol, you'll understand all the important bits that allow you then to perform an appraisal.
Okay.
We don't quite have time to go through all that, but in the next session, that's what we'll do. How do you build a protocol? What elements of a systematic review should you look for?
Okay, thank you.
But I'll give you a simple acronym. If you have a systematic review and you want to look at it very simply, the simple acronym we'll talk about is QFAS: question, find, appraise, summarize. So they should have a clear question. And we've just showed you what a clear question like a PICO. They should have a strategy to find all of the evidence. That should be 2 or more databases. They should have appraised the quality of that evidence in some way. Obviously, the best way to use that is something like grade, which is assessing the risk of bias. And then they should synthesize the evidence. And that may or may not involve a meta-analysis. If it's appropriate to do one, we would expect one, but sometimes it's not appropriate. So a simple way of thinking of it is question, find, appraise, synthesize, QFAS.
That's so much helpful. Thank you.
Yeah. One of the just before you do, one of the most important things about when systematic reviews say they're systematic reviews, the most important thing we find is often they are not. And there are 2 important elements. One is they have a systematic search, find. So if they're not, and 2 is they appraise the quality of the evidence. If they don't have them 2 elements, they're not a systematic review. They're a literature review. And there's no value to us really using literature reviews, apart from literature reviews are helpful for our general questions, filling our knowledge gaps. They're useful for that, but they're not useful for making actual care and decision and actions.
Thank you. We will go to the next person, Zaina.
Hello. I just want to ask a question about PICO. So when we are comparing our intervention, do we always compare it to placebo?
Well, good question. Very good question. So there are 2 things happening. One is if you've got a drug intervention, you would expect it to be compared to placebo. But often some people, if they use an open label design, they might use an intervention compared to usual care plus placebo. You have to be very careful if you have a new drug comes along and it's comparing it to inferior care. So that's one. Second, non-drug interventions, sometimes it's very difficult to offer a placebo. So for instance, self-monitoring of hypertension, you can't have a placebo. So actually what you do then is self-monitoring of hypertension compared to clinic-based monitoring. So it might be a different type of monitoring. So often you'll be comparing it to placebo as drugs and vaccines you would expect to be placebo, but non-drug interventions particularly, might be comparing it to something else. So a good example we had recently, somebody was interested in a new type of diet, for a ketogenic diet for diabetics, and they said, well, you wouldn't compare that to no care. You'd probably compare it to advice or standard advice or some other form of intervention. Now, importantly, there are also times when you've established the treatment works, but actually you may be doing a head-to-head comparison. So that's another time you may be drug A versus drug B. And I think that's a time when you might not see a placebo. So I think it's often needs a little bit more thought. And I think it's a good question. Not always do you use a placebo.
Thank you.
Okay, so we have also Muhammad. Muhammad, you can go ahead with your question.
Yes, hello, doctor. My question is, how much time should it take you to evaluate the systematic review to know it's a good or a bad review?
So there are two questions. Good question. One is, how long does it take me to evaluate a systematic review? Well, look, things take a long time if you don't keep up to date and practice and develop the skills. So if you do it once a year, it'll probably take you for quite a few hours and you'll be frustrated. But if I'm appraising the quality of a systematic review, I would expect it to take a couple of minutes. Now, often if we're going into more detail, but we can do a rapid appraisal in a couple of minutes. Now, if I'm writing a policy document for the local guidelines or X, it will take me maybe more than that, half a day, but it won't take me long. And so rapid appraisal can be done in a couple of minutes. And I think it works because you understand the basics of how to get round papers and you understand what you're looking for. You know, I don't just read the paper from start to beginning. I go into targeted to the information I want to extract. And in doing so, you become efficient. Now, that's exactly the same if you're going to do a systematic review. I mean, the first time you do a systematic review, it could take you up to a year. But if I work with my team, we can do them in weeks or months because we're really efficient at what we do. We know what we're doing. We have strategies. We've devised them and we keep practicing them. So we're really efficient in our processes. So most things can be done efficiently if you practice. And I think evidence-based medicine is a skill. And because it's a skill, if you don't practice it, you won't be any good at it. And the major one is to ask clinical questions. I mean, if you're really efficient, you can look up a systematic review in the consultation if you want. And I've done that on a number of occasions to help me inform the decision I'm about to make. And that happens because of the general practitioner. Sometimes I see things that I might not have seen for quite a bit of time. So I want to make sure I'm up to date.
So the idea here, or the key concept here, is to stay updated and to keep practicing with the years, so you become a very good, let me say, practitioner at this particular skill. Am I right?
Well, yes, let's just roll back. We have a number of visitors to the centre, and if you ever came to Oxford and visited me and said I practice evidence-based medicine, I'd say to you, okay, what was the last clinical question you asked about patient care? Tell me about it. And then I'd go, what did you look up? What did you find? And then only then I go, oh, that's interesting. What were the issues within the study? So that's step 4. No, step 1 is actually being really curious and realizing how many questions there are in clinical practice. Most people don't go, how common is this? You know, because if it's common, that has a huge impact on what's going to happen next in your decision making. So in doing so, that sets your pre-test probability. And your whole way of thinking is now going in a certain direction. So if a patient turns up with a fever, you're thinking, well, what's common in my setting? And then you're also thinking, oh, what are the serious harms? What don't I want to miss? And then you're thinking, what symptoms and signs, what tests can help me here really be effective and efficient? So I don't waste resources and I don't waste time. Often what we also see is, overuse and over-medicalization because people don't understand the limitations of treatments and the benefits and harms. And often I'll say to them, oh, that's really interesting. If you was in clinic, could you explain to me what the benefits and harms of this treatment we're about to use, please? And then I'll go, how are you going to explain that? Okay, you've explained it to me. I can, but there are about 5 terms the patient's not going to understand. How are you going to explain it to a patient? So take a, and there are lots of really interesting examples like, I'm going to treat your blood pressure. This is your blood pressure. What's your risk? How much does the treatment reduce your risk by? Why is this worth taking? And I think if you get that mindset, you'll actually find learning medicine much more interesting. You can do some of it on your own. That's where I said you can be more efficient. But also what you'll find is you'll become a valuable resource in your setting, and you may end up thinking, wow, I'm going to really teach this stuff. This is a way to think about how you learn and go about teaching medicine. So the appraisal is step 3, 4. The number one skill is asking questions, finding the best available evidence. If you can do that really efficiently, then the next bits follow on. But I'd start with step 1 and 2.
Yes, Steve, thank you.
You're welcome.
We still have some time, so if anyone has a question, feel free to raise your hand. I also saw one question in the chat, but I'll give you the chance if you want to answer it now or in the next session, because they were asking about the appraisal process again and the acronym, like how it can help.
Okay, so yeah, good. So actually, I'm going to put it in the chat. Okay.
Mm-hmm.
So question, find, appraise, synthesize. It's QFAS. Is there a clear clinical question? 2, did they find or attempt to find all the available evidence to that question? So for instance, if it's a treatment question, you'd be expecting them to have a clear clinical question, and they are looking for all the randomized controlled trials to address that question. That may be 2 or more databases, but it may also be an attempt to find the unpublished literature. For instance, did they use a clinical trial register? Did they do a bibliography or reference search, a strategy to find all the evidence? Then they appraise the quality. No quality assessment, no systematic review. It is a literature review. That quality assessment must look at the risk of bias within the studies. In synthesizing the evidence, there may or may not be a meta-analysis, but there is an attempt to synthesize the evidence in some way that is meaningful and can describe the benefits and harms. And then Maha asks, how many years ago should a systematic review be published to consider it's outdated? There's no hard and fast rule to this. Some systematic reviews may be 20 years old and they're currently up to date because they addressed the question. They found an intervention that was effective, and actually a good example of that might be aspirin in myocardial infarction. Those systematic reviews were done in the 90s. There were sufficient trials to be able to say the effect is stable irrespective of what happens next, and there's sufficient information to address the question. And if you wanted to look up, that's called the optimal information size, OIS. Optimal information size says you have enough power to be able to say this is statistically significant effect, and therefore we don't need to update it. Whereas if you have a new drug that's emerging, there may be 2 or 3 trials, but there may also be 5 or 6 trials on the clinical trial registry that are about to publish. And so that could be out of date within months. And therefore, people have a new strategy that's emerging, which is called living systematic reviews. And living systematic reviews are an attempt by the group to keep the review up to date. And in doing so, they basically are looking into an approach which says we're keeping our review up to date because we're aware that actually there's more evidence out there. I think hopefully you should be able to see that. It's a link to the Cochrane community about systematic reviews, and there's about a living systematic review. So there's no hard and fast answer. But if you do a systematic review, it's 5 years out of date, you're aware there's some new randomized controlled trials that are not incorporated, then it's out of date. End of. And so that's when you decide to update it. And I think that's how we look at it. We find the systematic review, we see what's been published since that date. And an easy way to do that is sometimes you can just look at their search strategy and go, right, what were their search terms? We'll plug them in, see what, and you can limit your search by the dates or using the filters. What's been published since 2021, for instance.
Okay, I think we might have some time for another question. Asil raised her hand. Go ahead, Asil.
Thank you for your time, Dr. Heneghan. I would like to know your opinion about integrating the evidence-based medicine with the currently applied guidelines in the clinical practice. I mean, of course, for the long term, we should aim to update the guidelines, but in the moment, how could we integrate it?
Well, look, I think there are two aspects. We use in the UK lots of guidelines, National Institute of Clinical Excellence, and there's a very good resource I point people to, which I use a lot, which I say is really helpful for teaching. Let me know if you can. I'm going to put this in the chat. I use clinical knowledge summaries a lot. I really like it. It has lots of interesting information about conditions. Can you see that okay? You know, and it's really helpful. So you can go and search up topics like atrial fibrillation but importantly within the guideline is guidelines will become out of date. Second is within a guideline, there'll be recommendations that are based on high quality evidence. And those recommendations are the important ones where you'll find systematic review, but there'll be other ones that are based on opinion and lower quality evidence. And that's where there's uncertainty, which is about important that you as a clinician should retain your clinical expertise to be able to interpret that and say, well, sometimes this applies, but sometimes it doesn't. And actually, I'm abreast of where the important evidence is that keeps me up to date, whereas this guideline isn't up to date. And so I think whenever you look at a guideline and you get recommendations, look, practice will be pretty boring if all you say is I'm going to take the guideline and do as the guideline says. But if you separate it out into two things, where's the high quality evidence-based recommendation? So if I did a guideline on heart attack, it'd be quite clear when they say give aspirin, that's a high quality evidence-based recommendation and most clinicians will follow that. But there may be other recommendations that are based on lower quality evidence. Do you know the difference? If so, are you aware of what the evidence says up to date? And I had a classic example the other week where, particularly in areas like pediatrics and children, lots of the evidence base in guidelines is based on opinion and consensus, and often might not look at the systematic review and evidence. So I personally believe practice is much more empowering if you're sharing the up-to-date evidence with your patients. Yes, there are times where the guidelines help you practice clearly and efficiently, and I think it's worth understanding within the guidance, if you do look at guidelines and you learn about them, separate out the high quality recommendations from the low quality, because the low quality ones should be saying in the context of. So often they may be saying this should be done in research, or within WHO, they use grade to say it's a weak recommendation, which basically is saying you may offer this patient, you may not, but it's your clinical expertise that will come to a judgment. If you think about guidelines like that, you'll find them very useful. If you just find them as a strict menu, if you like, to tell you what to do, I think you'll find practice quite disheartening at times. So I think that's how I see and how I use guidelines.
Thank you.
Okay. I think we have time for one last question. If anyone has like a question before we finish this session, feel free to raise your hand or write it in the chat.
maybe I'll finish then with what the strategy is now. You basically have a team-based exercise. Yeah. Think about the patients and the problems you see. Try and get together and then formulate a PICO, and then prioritize some of those to find the best available evidence. See what you come up with. Filter it out with PubMed for the systematic reviews and see what you come up. See what populations, what's the date and time of it, what were the outcomes of interest? Does it help you address the populations and patients you see in your practice? Or is it about something over here in America that actually is totally irrelevant? If so, is it up to date? We'll think about the appraisal next time. If not, could you basically think about, is this the sort of thing we should be doing a systematic review on? That's where you are now. And that, will be an interesting, if you choose to pursue it, the sort of start of your journey into evidence-based research.
Yes, thank you. Thank you so much for that. And thank you for your time.
You're welcome.
We're really happy to have you with us here. And we are happy to have you in the next session as well.
All right,
I
excellent.
hope everyone will do the the homework you gave us.
Well, the next session will be much better if you have a team and you come and you think, oh, we've got a potential question. Then you can start to think, well, we could appraise this review, but we could also build a systematic review and think about how we go about that. All right?
Mm-hmm. Mm-hmm. Yes,
Excellent.
maybe we will do we will separate them into groups. Yeah, we can do that.
Yeah, that'd be great.
Mm-hmm. Thank you again so much
You're welcome.
for being with us, and thank you
welcome.
everyone for joining us. We will see you tomorrow, and don't forget to fill the feedback form and to know that you participated with us. And if you have any questions, feel free to